Well, welcome everybody. It's at the top of the hour, so we'll go ahead and get started. Welcome and thank you everybody for joining us today. My name is Misha Adams. I am the Clinical Informatics Chair for the Minnesota FHIMSS chapter, and we're very pleased today to have Mary Tietze with us today to discuss the maturity of EHRs and the maturity of the professionals who implement them. Just to let everybody know that this is being recorded, so can always be viewed again later. It will be posted to our Minnesota FHIMSS site for future viewings if need be. Mary will go through her slide deck, and then at the end we will have a short Q&A session if time allows. So welcome, and Mary will let you take it away.
That is my intention, to leave time for questions. That's where we have the most dialogue that's useful. So thank you so much, Misha, for having me here today, and also for Bert Hill for kind of getting us started. Also to my colleague, Dr. Gabriella Wilson, who actually was, the discussion with Bert came from her, and I was available to present. So that's why I'm here today. So it's great being in the FHIMSS chapter of Minnesota. As you know, I'm from the Texas chapter, actually the Dallas-Fort Worth chapter of FHIMSS. And as you can see, I'm an RN by background. I've been in informatics since 1980s, absolutely implementing systems way back when they were called bedside computers. So this is a love of mine. I'm at the point of teaching it now at University of Texas in Arlington. So I would like to go ahead and talk about the discussion about maturity of the EHR. I'm going to go ahead and share my slides, and they'll be, Misha will make those available as well. Okay, so just to check with Misha, if that looks okay. Awesome. So basically, the role that I have is a professor at the university, but we are an interprofessional. We basically work with all departments: computer science, public health, master's in social work, kinesiology, through the, as you can see, the third line there, the affiliate to multi-interprofessional center for health informatics, as we call it, MICE for short. And it's basically facilitates us all working together as one when it comes to health informatics and meeting the needs of the community, those that are diverse, those that are underserved, those that are in the areas that need social determinants of health and so forth. We're finding out that the conditions of those that we care for, where informatics comes into play, are complex. And so we have this process in place so that we can do the best work together this way. So I wanted to point that out. And today, what I'm talking about is the maturity. So these are just three real objectives here. Okay, by the time we're done, I want to be able to describe the maturity of EHRs, okay, and the relationship to user satisfaction. The other thing is to describe the impact of that maturity on professionals involved in the actual implementation. And then the third thing is to explore actions that contribute to maturity and the maintenance of the EHR, over time as we develop care. Then there's just basically outline actions. I'll leave you with some actions as possibilities to think about. So the background in the beginning, okay, you guys remember where this all started, right? The HITECH Act, right? In 2009, where they made bazillion dollars available for us to create and implement electronic health records so that we could digitize healthcare. And if I remember correctly, the main objective was to not have duplication of MRIs and duplication of tests like that. So the HITECH Act drove a lot of this, and it actually caused us to implement pretty quickly, a lot of pressure. And then, of course, there were criteria but those EHRs starting in 2010 were going in fast and furious. The TNA, Texas Nurses Association, seeing this, the second bullet there had focus groups going on, and that illuminated the rapid uptake that the nurses were experiencing of the EHRs, going from paper to digital. And then those were both in hospitals and ambulatory care settings. They found the nurses were faced with an increased burden of the documentation. Does that sound familiar? And also the poor usability of the experiences. And they were interested in this because of the impact on patient safety and quality, and their experiences not only of the nurse, but of the ramifications of that. So with that being said, they created a health IT task force, of which I was the first chair in 2010. And we were to document the effect of the EHRs, and so that we would have some kind of quantitative and qualitative information to go on to improve the situation. So we actually came up with a statewide study, and that was directed with a combination. And this was the key to our success, I think, in getting it as many samples we did. It was a combination between Texas Nurses Association, which is the practicing nurses and the educators, and the Texas Organization of Nursing Leadership. And so those are the CNIOs, the CIOs, the CNOs of the leadership in organizations. So the partnership made for an ability for us to actually be successful in that and gather information that we needed. So we kind of looked at ourselves like this, okay? In the upper right-hand corner, this is kind of our framework for the study that we were going to do. And we were charged by the board of directors of the TNA to document it over time. So you see the far right where it says benchmark reports on progress. So it wasn't going to be just a onesie, one on. It was going to be let's see what's progressing over time. So there were environmental factors going on at that time. That like I said, the EHR incentives, the Robert Wood Johnson report was coming out. A lot of IRO was going on, and so that was our environment. But we wanted to also use as many of our stakeholders as possible. So we engaged with the FHIMSS organizations, the nursing informatics organizations. Tiger was a big component of it too, in terms of getting our gathering of what this is all about. And so we also then noticed, if you look at the big heart, deep in the heart of Texas, I don't know if you remember that song or not, but there are almost 500,000 of the nurses. We're talking about all walks of nursing, including the certified nurse assistants. So that's a lot of nurses that this was going to be affecting. And so that being the case, we then decided that we were going to create an awareness campaign. As you can see there, we were going to help the schools of nursing with curriculum development for education, and then also support practicing nurses with CNE as we get them updated. So those were just, along with the study, some things that we were going to do, and of course involve constituents. One of the big constituents was the Texas Hospital Association. So that was the component there that worked with us as well. So that was our framework. So going into that, and this is the team. It took a lot of us. As you can see here on the far left is the team of Texas Nurses Association leader, which was me, and then one from the Organization of Nurse Executives, which was called at that time in 2010. And then these are all the TNA members that were supporting the committee, and then also the nurse executives. These on the 18 angels of mercy over here are the ones that actually are subject matter experts. And you'll see in just a minute that we actually created our own tool to measure maturity. Okay, so those are the people that we use as consensus builders as we created that particular instrument. So the methods that we did for our first study, it took us 5 years. We started, I know, it's like, well, the EHRs were going in fast and furious. And it was 2015 when we actually started gathering our significant data. And then we also repeated that same study in 2020, and that's what I'm going to be talking to you about today too. But it was a statewide multi-organizational study using consistent methods to describe and explore the survey of the experiences of nurses. So the key issues were the current deployment of EHRs, so we were targeting on that, and then characteristics associated with the satisfaction of those that were satisfied. But we also had a covariant. So those of you in statistics realize that sometimes, when you measure, let's say, satisfaction, there's another factor that actually can be boosting it or actually bringing it down, affecting it one way or another. So we felt like the maturity, how functional the EHR was going to give us a true picture of satisfaction, not just, I hate this, for no reason, but also, oh, look, it's not very functional. So therefore that may be the factor there. So the maturity of the EHR was one thing that we had another tool for. The one about just basic satisfaction was called the CISO, and I'll talk about that in just a minute. It was a well-established one at that point. The one we created was called the MUMSI. I know we always have to have these acronyms, right? So I'll explain a little bit about that in just a minute. So the first page of the survey was an online survey that went to, it was a snowball effect. So all the CNOs at the hospitals, okay, whatever jurisdiction they were over in the 600 hospitals in Texas, they would send those out to all their employees' emails. And then we determined if they were, so they're, whether it was, they qualified for the study. So they were filtered out. So the nurse certified, the chief nurse executive didn't have to. So it was very simple to deploy. And then from that, we then could not know who they were. This had to be anonymous. And we couldn't know what hospital they were from, but we could know what region of Texas they were from. So can you see the map there where we've got the health services research districts of the state of Texas? And they just basically said, they picked out which one of them that they were. Okay, so we knew whether it was up in the, whether it was Panhandle, whether it was, east, west, border, that kind of thing. But we did get some demographics about them, like their age, how long they've been in nursing, what is their basic practice, specialty, and so forth. So some demographics were collected. This took them about 15 minutes to complete. And so then here is the CCs. It stands for, as you can see here on the left, Clinical Information Systems, which is what we used to call these things. Before EHR came across, and it is a global term, okay, of systems that help with delivery of care. Implementation, evaluation, scale, okay, so it's stuff like, as you can see here, overall, like number one, I prefer using the system than the old way, okay, so it's kind of gauging what the impact has been. I can depend on the accuracy of the system. So these are statements, okay, there are 36 of them. And then you can, they're on a Likert scale. And so the more positive would be, I strongly agree. And I think some of these are reverse coded and so forth, but it's all about the higher the satisfaction is, the higher the experience of implementation. Nothing about the system itself. And that's what kind of bothered us, and we wanted to do something besides just the satisfaction. So that's what the other thing is on the analysis. The people who are strongly disagreeing, those matter to me. They do matter as a researcher and as I do the analysis. And the one who strongly agree also matter. Those in the middle, not so helpful, okay, when we try to figure out what are the factors that go along with this. Okay, so then this is an example of the 2 years of study. So we have here the 2015 histogram, which is the scores of satisfaction on a scale of 1 to 5 for the CCs. And our top score was right here on the right side of the bell curve. So, it was in the neutral zone, as you can see here, between 0 and 2.5, puts it at about, indicates neutral or not completely satisfied. And then what happened 5 years later? And again, remember, we were this great team that were going to use the findings and implement. Remember, I said we're going to do a campaign of awareness. We're going to do curricula for the schools. We were going to, we had a plan and we did it. Look at our study. Didn't really change. Okay. Pure satisfaction pretty much stayed the same. In fact, it went down a little point or a tiny little decimal point. So again, the sample sizes were at about 1,000 on each one of those. Well, 870 there and not everybody came into this last evaluation part of it. So 767. Okay. So we're like, okay, didn't make as much, it didn't make progress that we thought we would, but we weren't that concerned. We found out a lot of information about it. So that's how the CCs work for us. So the other tool that went along with that is called the Meaningful Use Maturity Sensitive. So it's Maturity Sensitive Index. Okay. And so it's sensitive to how much functionality or maturity there is in the system that the respondent is going to be using to tell us about satisfaction. Does that make sense? Okay, so this is what took us so long and all the subject matter experts that were necessary. We gauged it on meaningful use 1, stage 1, which was back then what we called it, right? Now it's promoting interoperability, PI. But this is when it was MU. And these are some of the examples. In my facility, the electronic health record that I use includes a computerized provider order entry system for directly entering medical orders. And they would say it's either present and used, and then present, but we don't use it. Or, that we don't have that. Or that, I just don't know. So we left an I don't know as an indicator to us as to how much was known about the systems as well. And so another one might be that my system initiates alerts when a medication order results in a possible drug-drug interaction. Okay, so it went on. There were 24, of these. So 36 of the other, 24 of these. They're done in 15 minutes and just pretty easy. The thing about it is, though, this is maybe what talk more. We left it a big 1,000-character box at the end of the survey. And we said, please let us know what we may not have asked that you want to tell us about. Oh my goodness. Okay. 352 of the 1,000 left us paragraphs of information. And that's what we qualitatively analyzed as well. Okay. So the I don't knows were analyzed too. So now what we have is what we did with it is we covaried the satisfaction to the functionality. So as you can see here, all those people who said yes, they were satisfied. Okay, look what their meaningful use MUMSI index happens to be, 64 out of a possible 72. Okay, so high functionality is associated with high satisfaction. Those that were in the no, not happy, they're in it's not a big difference, but it's statistically significantly different. And that is, they're in the 58. So it's functional, but not as, so that top part of getting them to the higher functionality of those other items is what makes the difference between the two. Okay. And so you can see the p-value there of the MUMSI means comparison of nurses indicating satisfaction, yes or no. And there was a statistically significant difference in that. So now this is let me explain a little bit about all the factors involved, because this is where the I don't know comes into place. Okay. So when we did the MUMSI, it was the first time. So we wanted to know what did the factor analysis look like? How did the items cluster together or not. Okay, so part of that is that this is called the path diagram of all of these are the items of the MUMSI, the 24 items, and they're in different spots in terms of how the scores cluster. So there was a part of the scores that clustered together on patient status. And so those that commented on, that had scores on patient status, these clustered together. There was another one that's called, it's where that the system generates information for us. Okay, and that was those items there. The third factor had to do with nursing care delivery, that it allows me to do these functions. And those are, again, all that in that meaningful use. And then the fourth one was clinical decision support. It gives me drug-drug interaction. It guides me in certain steps. Okay, so what we found in the I don't knows, the ones that they were most I don't know about, they were pretty knowledgeable, is number 2. Generates system. The system generates patient information that can help me take care of the patient. It generates patient problem lists. It generates knowledge, discharge statuses, information for discharge. So that was an area where we felt like needed to be more, if they knew the system did this, then they would have more understanding maybe of the functionality. And that's where understanding your staff and the users would then be, that would make it clear to you. But the study then showed that. The others were not such a big concern, but that number 2, that not knowing that the system generates information for me to help care for the patient. And then this is just the details of these. Okay, so the highest ones on this, let me read them to you that I've got them circled, is EHR, electronically reports targeted information related to public health and disease prevention. Examples are reportable health conditions, immunizations, and laboratory. That was a meaningful use item that the EHRs were specific to do. Another one that's higher in the 40 counts that had high I don't knows is, in my facility, the electronic health record generates lists of patients by specific conditions and quality improvement. Okay, again, an item I didn't know, and this is in 2020. And then another one was there's electronic health records capture and display advanced directives for patients 65 or older. Requirement, didn't know. So that's just another piece of information that gave us a little insight into the users. So I told you about the dialogue that was written into the 1,000-character boxes. And I wanted to just point out a few of them. We of course, can analyze them and so forth in certain ways. The difference between 2015 and 2020 is they just seem to be a little bit more knowledgeable. Their terminologies were a little bit more sophisticated, but the same thing happened. In this case, it was patient safety. This particular EHR is very fragmented, insufficient, inefficient. Additionally, not all physicians utilize the EHR. That's true today. On the study that, if you've read the site that's called Death by 1,000 Clicks, they again, it's just the reality of what we're here with. It's a normal bell curve of usability. Therefore, the patient is negatively impacted, and one never knows if all the information is actually in the EHR. Now, when we had the paper chart, not an issue, right? We didn't know where the information was going, but the biggest thing was losing the chart, right? Remember that? I like that, we can't find the chart. But here we have, there are too many areas that are great concern of having negative impacts on patient safety. And then similarly, we're saying it again, here is about the handheld unit and where it's located in the chart, in the room. They have safety concerns. I can't see the patient when I'm needing to document. Patient safety is an issue, and whoops. I feel our EHR could have some better features. So that's just on the side of that. On the ethics, there was some ethics issues. The workload by a minimum multiple increases my workload by a minimum of 2, which can only equate to 0.5 times the time I have provided patient care. I should never have to make a decision on whether my time is spent charting or on my patient. My patients will always come first. Such and such system has taken the valuable time I have to spend with care of my patients and suffocates my time into documentation. This is, again, on the extreme, but it doesn't mean that it's not a person who needs to be heard. And I think that's a little bit of the maturity of the implementers to be aware of these kind of experiences in the users. Workflow. The key is to having a successful EHR is having related investment in organizations willing to make. It's imperative that facilities have high quality intuitive systems that navigate users, does not distract them from what their systematic way of doing things, right? So that's what we're all aiming for. But this is a nurse way, back in 2015 telling us that the CDS needs to be limited. It can't be overwhelming. And nurses spend too much time playing historian to be able to satisfy the clinical decision support requirements. So in a nutshell, the themes that we came across were information system design, professional ethics. This is on the qualitative side, patient care quality and standards. This is what they're talking about, and then organizational and social justice. Feeling I'm saying this, not being heard, I'm saying this, and it all comes down to competency. Now, competency is a great word, and we like to use it a lot. I looked at competencies that we should be expecting from implementers, leaders in information technology, and they have great terms about what we're supposed to do, and they even talk about having the user involved and having them at the table. All those kind of competencies are great, and I think they're laudable. I know everybody's busy with their time, and we're trying to get to that. So they're there, okay? What we might be thinking about here is that maturity is a system of competency and compassion, or compassionomics. And I don't know if any of you have been familiar with this book by Stephen Tietze and Anthony Marzarelli, but it's the domain there is what they're studying has to do with patient outcomes. And we're pushing these compassionomics down at the user level. Not only does the patient need to experience compassion from the providers, but so do the providers themselves. So if you let me just bear with me, just explain a little bit about this. Marzarelli is a physician executive, emergency physician, lawyer, and bioethicist. At the time, he was working with Tietze, and their point there is one of them is a researcher and one of them is a surgeon, and they got together and they asked themselves the question, does treating patients with more compassion really matter? Does caring make a difference? And does it matter that in a measurable way, put it as a scientific rigor, they thought that wasn't possible. How can you measure whether compassion is having a difference on outcome? So they wrote this whole book, and the book time after time after time shows that compassion will make a difference. So their summary basically is the presence of compassion, and we'll define it in just a minute, has the power to improve patient outcomes, and its absence can lead to devastating, even fatal consequences. Additionally, it has substantial impact on healthcare costs, both patient and to the overall care system. So insights that the data provide to both caregivers and healthcare leaders has the power to change both the delivery of care and the way in which we these systems are managed. So I'm bringing that into, because maturity, as I say today, has to do with a component of compassion. And those are the items that we wanted to accomplish. So the word literally means to suffer together. Okay, so I'm suffering with you, and it has to do with action. So compassion literally means, and then among the emotion is defined, it's a feeling that arises when you confront with another's suffering. Okay, but the difference between compassion is not empathy. Okay, is that you actually there is some action that goes along with compassion. And this is from the greater good science. Okay, and so what this organization has done in terms of compassionomics is they've started an all-in well-being first for healthcare. And the well-being for healthcare has to do with, I guess we've been through some tough times through the pandemic, but it's about acknowledging that it's the ultimate and most meaningful embodiment of emotional maturity. And it is through compassion that a person achieves the highest peak of deepest reach in his or her search for self-fulfillment. It doesn't take a lot of time, as the book indicates. Now, these different acronyms, these little dialogues here, have to do with 5 points that they put together that will be used for doing something today, now, in a compassionate way for the healthcare providers. The one in the upper left-hand count with the 4 lines is not normal times. These are not normal times that we're in. And so how do you deal with that? The one with the heart is that ERP that we all have available to us is not enough, not going to cover it. The ones with the hands raising up is getting radical with shoring up staffing. And of course, we all know that too, but there's some suggestions there. The one with the people is that designate a well-being executive. So it doesn't take your VP of something or other, but also say, you're the well-being executive. That's what we want to define as how is the well-being of those that are in our employment. And then the one with the 4 arrows coming together is get rid of stupid stuff. Okay, so then there's some details that go along with that in this webinar that is available on YouTube. I watched it, and it's basically taking each one of those in more of a detail. They call the Wellbeing 5. And it's a campaign that was launched about 3 or 4 months ago, as a result of compassionomics and the whole movement towards that. And it gives you some details about how to get that accomplished. I'm bringing back the triple aim. Okay, the triple aim had to do with taking the patient, the cost, and the right care. But the quadruple aim is about the provider. Okay, it's adding to, if you don't have care for the provider and a a healthy, provider, the other 3 aims aren't going to happen so well either. So this has been out a while, 2014, if you have ever heard about the quadruple aims. The joy of practicing. I can't tell how defeated I feel. I am no longer a physician. So again, it's brought from the physician angle, but it has to do with all healthcare providers. And so basically the results of our study brought us to this awareness, but there was no significant difference in the overall satisfaction in 5 years of what we studied. The mean satisfaction scores went from 1.04 to 1.94, not statistically different, respectively, with this being in the neutral zone. Okay, and I don't know the proportion. I don't know proportion from 2015 to 2020 didn't really change that much. It changed in some of the items, but like I said, the one that had the most I don't knows was how the system can actually help me take care of the patient. When accounting for, so in summary then, when accounting for the EHR functionality maturity, these results indicate that it makes a difference for the improvement and the overall satisfaction of nurses if the maturity of the system is there. So keeping that in mind. But there's also the maturity via those implementing it and those involved with it, to be sensitive to those that are involved with the EHR. So the last bullet, maturity via compassionomics on the healthcare professionals implementing EHRs could positively impact the user and the EHR experiences. So you see what we can do with patients and their improvement of their outcomes with compassionomics. I think leaders can do. Even the IT person who is on the phone. I know that they're tired and they're getting 100 calls a day, but just the tone of voice, just I care about what you're experiencing. And I know a lot of them do that, but it's not a mantra. It's not something that we embrace. Be compassionate for feel their pain for those that you are involved with as you're implementing these technology systems. So just to close with that, I wanted to let you know that we've got the link here of the tone. There's a resource tab where we do have all our webinars and all our tools that we put in place to support those using the electronic health records. It's an open to the public. And also we have the actual study, both of them. 47 pages if you're interested in going through that much, where we have the actual details of the study themselves. I've done a high level today as it associates with maturity of those implementing the EHR. And that takes me through what I wanted to cover. And thank you so much for your patience and letting me go through that. I'm hoping that we've generated some thoughts on your part. And I'll let Misha kind of manage that. Misha?
Yeah, so if anybody has any questions, there is the Q&A function in Zoom. Otherwise, if you want to raise your hand, I can go ahead and off mute you guys too if you want to ask a question. So. Because I think I have a question for you, Mary. So I think it's the question of the sweet spot with maturity. So, when you survey these nurses and I don't know what, I'm not satisfied and I don't know what's there. And a lot of those things they didn't know were meaningful use things about, reporting out and interoperability. And I know I had a joint commission visit at an old client of mine that they had asked the nurses about healthcare directives, and the nurses didn't really, they knew some spots of it, but they didn't know it was a reported thing that they had to be on their toes necessarily being asked for it. And so I think it's that maturity of the why. So, is there recommendations, I think, from your experience of when you do implement EHRs to help with satisfaction, instead of just saying, hey, this is a field you need to fill out, how do you help nurses and frontline staff understand the why behind a lot of the things that go on in EHRs?
Oh, it's definitely the why is helpful for them to connect the dots. It'll help them when they're getting those frustrated moments, right? Whenever it's like, not this again, So definitely explaining the rationale. And I think that for the most part, well, maybe not everybody, but that is the way we generally teach is adult learners want to know why, right? And so, yes, the more of that, the better. The thing that I think is the sweet spot in terms of, helping from what we could see from the comments that were provided us by the nurses. They feel a sense of moral distress. And this isn't just nursing, by the way. I think physicians are, there's lots going on in their areas as well. Websites and mass and talking with CMS about this or that. So again, we have so much time in a day. And like the Compassionomics book says, it doesn't take that much more time to be able to say, I see what you're talking about here.
Mhm.
And I do want to make a difference. So that sense of exposing yourself, that way, I didn't see that. It was more of a, you know what, it's in and you're going to do it. We already have it implemented. This is how it is at this. I mean, they literally said, this is it. You have to use it this way. And that's not going to be a good down the road approach for anybody. So that's where the maturity comes in, where you just take a breath and go, okay, I see that this is really not working for you. Let's look at the governance committee. Let's do something like that can at least get them engaged to feel like they're being listened to. Does that help answer your question?
Yes, it does. Yep. And I think that's a piece that I know I've seen. I think that kind of gets missed sometimes, or it gets lost in the implementation, communication, and sometimes is that, to your point, the compassion and the why of what's and just upheavaled my workflow maybe, or like, why am I doing this? And yeah.
Well, and it's a team. Like there's actually called the Schwartz rounds in some hospitals throughout the country. They've actually assembled teams and they do compassion rounds. So it's the whole team that is talking in compassion terms with each other and right there with the patient. And it's called the Schwartz rounds. And it's a takeoff again on Compassionomics as a result of this work. So if you just imagine what it's like if everyone on the team knew that not only, and if I need compassion too, okay, not just everybody else.
Yeah.
And so if that becomes kind of a mantra, I think we're not going to change overnight these workflows, but we can at least be less painful in it by being mature in terms of the Compassionomics. So my 2 cents on that. I see there's a couple of chats I don't in there, but I can't necessarily see them.
Yep. So there's one question. There's 2 questions. So and they're kind of more of the follow-up to your study. So there's one that, is there any plan for follow-up of the study in 2025, and or have others indicated use for the tools used and interested in follow-up with that?
Thank you so much. That must be one of my colleagues out there, somewhere. So yes, so we actually have another study coming out. Actually, the state is Michigan, I can tell you that. And they did the exact same study. Okay, so we're going to have new information on the horizon for everybody in a different state, a very different state than Texas. Okay, and then there is discussion with California, another very different state. So we're very excited about that. And thank you for asking that.
Awesome. Yeah, and then is there any follow-up next steps or actions items as a result from your original kind of study?
So that was in the slide. Let me see. I kind of went fast through that. It was the one that I had the Compassionomics book, I believe, on it. In a nutshell, basically, right here. Can you see, guys? Okay, so this is where I said maturity is a competency plus Compassionomics. In all the competencies I looked at, never did I see anything about compassion. So basically what we said in our study is this gray box, okay? The nurse's role or the capacity to provide care is a theme, okay? That's got to be focused. And we said that you need to improve the interprofessional collaboration. This is an issue of interoperability and the information sharing. That seemed to be the biggest thing about them, that when they went from paper to digital, is the silos that tended to happen in terms of sharing of information. This other one, big one, the system design. We're all working on the system design, I know that, and clinical decision support and trying to predict sepsis before it happens and pneumonia, et cetera. That's all well and good, but we also need to be careful about the documentation burden that comes along with that, and improve the consistency across facilities too. So that, and again, that's it's again going to be a compassionomics process because these are tough issues to deal with. And then the quality of IT support came out big. Okay, when I need somebody at my elbow, I need them. Okay, and then the education that goes along with that in the implementer's role. Do not cut short on that. And so clinical involvement in systems design, function, and education, and then continued vendor support if it need be, and their vendor engagement along with that. So those are the in a nutshell. But the 47-page paper that is on the website that I have on the last slide there has all many more recommendations. These were the ones relating to maturity. And that's that site right there.
Awesome. And we have another question come up. Thinking about new graduate nurses, what recommendations would you suggest to support transition to practice? Are there areas you would focus on in undergraduate curriculum to prepare future nurses?
Oh my goodness. That is what we're so working on right now. And again, because the essentials in nursing practice changed, right? So for the first time, we actually have one that's specific to information technology. That means that it'll eventually be on the NCLEX test, okay? So yes, what we're doing there is at the undergraduate level and at the graduate level, don't tell them I use this word, but it's subliminally including technology and how it's used, and then actually data in the curriculum. Okay, so it's not like, oh, everybody's going to get a informatics course. Everybody's going to get informatics and data analysis and population health and social determinants of health. Not only talking about it, but using data. Excel will work for a lot of this stuff. And so that's kind of my target, is that we actually make nurses that are at least at the Excel level. I'm maybe going out on a limb here. That's different than how it's been in the past. So to a new nurse, and the new nurses that just graduated may be very much there. Okay, we're looking at the whole of nursing, and I think that is it. It's just connecting the dots while you do it in a compassionate way. Okay, the reason social determinants matter is because you can take care of a patient all day long, but if they don't have transportation to get to their visit, if they don't have a grocery store to get the right food they need for their diabetes management, you're going to be spinning your wheels as a nurse either way, or as a provider in any of the notions. So we're very blessed now and fortunate to have the knowledge from researchers to give us that. So we got to use it. Yeah. I hope that answered the question, but it's just subliminally, we're not going to change it, a drastic curriculum. It's going to be infusing.
I got a raised hand. So Michael, I'm going to click the button here and allow you to talk. I believe you should be able to unmute yourself. I'm hoping it's going to work.
Yeah, I could go ahead and stop sharing too. So I don't know if that I could, there we go. Let's see. Oh, that's okay. One of my proteges.
Yeah, Michael, you should have a mute button on your Zoom now to be able to unmute yourself.
And back to the next steps comment, if you wouldn't mind, Misha, is that what I gave you in terms of the links of all in for first for healthcare providers, and the 5 ways, those are my steps for you guys, is become familiar with that and become familiar with the Schwartz. If you get to that link that I gave you, or that site, then it brings you to the other things that are going on, and it'll just become a domain of knowledge for you.
Awesome. Any other questions from anybody else? Don't see anything.
Michael has a hand up.
Well, Michael, you might be double muted, but I'm going to lower your hand. And Mary's email was at the end of the presentation. So if you have a question for her, Mike, I'm sure she'll be happy to answer it for you via email. So
Definitely. And I hope to be back again with some more information for you guys.
that would be amazing. We'd love to have you back. Thank you so much, Mary, and thank everybody else for spending your afternoon with us.
Thanks, everyone.
Thank you.
Good to be in Minnesota.
Yes, thanks. Bye.
Bye.